Not the NHS again. This week it's just me. That's partly down to how busy it can be to try and get a podcast together, but it's also an opportunity to reflect on some of the other things that we've done over the last few weeks, putting these podcasts together. So I'm going to show you a few little clips, a few little highlights. But before they do that, I spent the last 2 days at NHS Confederation, which is a big jamboree for all the sort of great and good of the NHS who gather at in Manchester this year, and they have done the last 4 years. What's really interesting is how busy it is of people that are generally interested and passionate about the NHS, which is great. It's also quite corporate. There's a lot of corporate people, corporate bodies around. This year it was really obvious how much more AI was involved in the conversation. So AI here, AI there, AI everywhere. But actually, some of the tech that's being used is actually going to be really helpful. There's always concerns when we have these conversations around how much of the AI is going to be useful or helpful, or it's going to be obstructive to people that can't access health. People do seem to be listening to those stories. I went to some really good talks about how you're including people and making sure that the marginalised are not continually to be marginalised. So I've got to say, I came away from NHS Confed relatively positive. As you'll hear, general practice is often ignored, and there was a little bit of general practice stuff that goes on there, which was good, and I was glad to be involved in some of those conversations and discussions. The other thing is that the NHS is still here. We heard a keynote speech from the new Health Secretary, James Murray, and there's no more money, but he wants to change gear and try and make things go faster and quicker, which frankly they all do. But there are some good things in there, and people are genuinely passionate about the NHS. So as much as we do the advocacy stuff and as much as we've had these conversations, I've got to say that it's been really good just to be around people, to listen to some of those conversations. And I want to reassure you, our engagement, our listeners, that there is good conversations going on, but we need to keep advocating, keep pushing, keep encouraging conversations with our MPs, with those people around us, and keep saying that the NHS is here for a purpose and that there's need for it. Clearly, this is something we need to carry on fighting for, and it is worth fighting for. So let's just see a few clips. Let's have a little look at what was going on around NHS Confed and some of the other things that are going on. And I hope you enjoy some of the conversations that we've had over the last few weeks and just little memories of those. I'm back next week. We'll be back with a couple of podcasts that I'm recording next week. There'll be one next week and the one the week after. So we'll carry on with Not the NHS Again. Thanks for joining. So Not the NHS Again, a bit of a different one this week because here I am at the NHS Confed. We'll see what's going on. We'll have a few conversations with different people, and let's find out what Secretary Care is really up to. And you'll see there's lots and lots of exhibitors here. Lots of people trying to influence the decisions that are taking place at government level, but at NHS Trust level, and we'll have a little look at those as well. Bit of a wander through. It's just interesting to see the numbers of different organisations that are here. Companies like Novartis, Microsoft, Lilly, Roche, King's Fund. Lots of really interesting opportunities to connect, or alternatively to influence, and that's one of the interesting things around the NHS Confed. Coming as a GP, there's very little general practice that takes place here. It is pretty much hospital trust, with lots of influence being bought and shared, conversations taking place. So here we are at NHS Confed, which doesn't seem to be very general practice. What do you reckon?
Not at all. I mean that's always been the case, though. You have to remind people here that general practice exists.
Yeah. And it seems very corporate, doesn't it?
Very corporate, and I think you and I need to do our bit to make sure that they remember primary care does most of the work, most of the activity in the NHS.
Yeah.
Because all the airy-fairy plans they've got to improve the NHS are going to depend on general practice, and they need to get them on board.
Yeah, and I've been to quite a lot of the meetings. I've asked lots of questions and suggested general practice. They're ignoring it. Yeah, it just seems a bit bizarre. Anyway, I suppose there's a bit of a buzz around the place, and people are genuinely more positive,
Yeah.
I think. And I think, people actually believe in the NHS here, which is, I think, is a good thing.
Yes, there is a lot of goodwill about it. But the best thing about it, so you know what that is?
What?
It's in Manchester.
Yeah, it makes it easier for us.
And it's, the place to have any kind of conference here in the UK right now is Manchester.
Yeah. So come to Manchester, and you'll meet both of us, which will be great.
And so I've started talking about leadership as don't be a cock, be a chicken. And by that, I mean be someone who's curious. Be someone who's curious. Be someone who's humble, be inclusive, be compassionate, be kind, be empowering, and be nurturing. And I think those are some of the gifts of what leadership is really about. I think humility is the hallmark of leadership. It's about really being able to listen at a level that totally transforms and changes us, helps us do our deep ego work and our shadow work, and helps us become more fully human, more fully able to bring the best of who we are in the world. And I think a lot of the times, a lot of the bad behaviors that we see in leadership generally, both in politics and in public sector, is because we don't do our work on our egos, on our shadows. We don't become fully integrated as human beings. And so we reject part of ourselves, which then makes us able or more probable that we will reject others.
Unbelievable. Okay. So access to over 1 million NHS emails. And the other thing, I've spoken to people, in fact, back in 2023, before the contract was awarded, I actually approached the medical director in both the trusts I work in. University Hospital Birmingham and also Sandwell Birmingham. UHB, I know, has got no intention to install this, and the even latest stuff hasn't shown that. And at the time, both medical directors said they had no intention. But clearly, this is being pushed by NHS England. And in fact, Sandwell has got some limited involvement. I've spoken to people who've used it. I actually won't use the language that was described. But basically, it was described as a 4-letter word beginning with the word letter S, okay? And because it didn't actually do anything that other software doesn't already do. So it doesn't give any added value. Quite a large number of trusts don't really want to use it because it's not very good. And also it becomes a problem if other software providers try to use, you're sucked into forced to use the Palantir product, basically. So I suppose that's how they get their money, basically. And the amount of time that IT staff are actually having to use this. In fact, a number of interesting stories on this. So the Health Service Journal has reported on some of this, and both. I think it was down in the southwest around Bristol. They're actually having to put in IT time to find glitches in the FTP, which isn't working, basically. And the other important thing you mentioned about Peter Mandelson's firm Global Counsel, the chief executive of NHS Westminster, Matthew Swindle, who was also chief executive, I think, for 4 other NHS trusts in London, was actually working for Global Counsel. And when they installed the FTP in there, basically, and when the Financial Times revealed that he was lobbying staff that can we include primary care data on this, surprise, surprise, at the end of last month, he's no longer chief executive of Chelsea Westminster. No, that would have been a complete breach of GDPR. And also there's been a shift in time. When I first became aware of this, actually, Palantir were very much focused on primary care and the single patient record. And I think what happened, those of us who are old enough will remember the care.data scandal and how much money got squandered on that, basically. I think they soon realized that GPs are independent contractors and therefore would be the data controllers and therefore would have legal responsibility for that primary care data, and basically told everyone where to go. So there's been a shift. So the Federated Data Program to try and get this into secondary care. But as you can see, there has been reluctance for all sorts of reasons, not least that people find it's not very good. And in fact, a really, really interesting post, I'll just look it up, from Dr. Jess Morley, who's actually, wait for it, drum roll, used to advise the Department of Health on artificial intelligence, okay, where she pointed out the failures of the FDP.
Crazy.
That's not just us saying this. This is, experts that were advising the Department of Health.
How did you end up writing a book, and what are you doing?
Basically, this is a sort of a passion project of mine that was never really supposed to be a book. I mean, it spent the last 15 years as this notebook.
Wow.
I wrote it for my kids. Basically, I was told to go home and get my affairs in order about 15 years ago. And it suddenly struck me that I'd been on this really horrific journey, and that everything I'd had to learn the hard way was sort of going to get lost. So I started writing it for them, so that they would have a guide. And I happened to mention it in passing one day to my agent, because prior to this, I wrote fiction. And she just said, stop what you are writing. I need this book. I need this book. I'm looking after my parents. I need this book. I'm looking after my baby. And then suddenly, and it was brilliant, because Short Books jumped on board. So that's the publishing home of the late, great Michael Mosley. They could really, really see the value of a patient-to-patient guide, because I do think it brings another sort of a nuance and level to it. And certainly we've seen the How to Talk community on my Instagram feed. They're so engaged, they're so concerned, they have so many health issues that they don't necessarily feel are being addressed. So this book is what I'm sort of calling the ultimate guide to navigating the healthcare system, your healthcare journey. And there's a lot of emphasis as well on sort of making it a family affair, bringing your children in early so that they learn how to communicate, with their healthcare providers. Because, I mean, let's be honest, the NHS, it spent the last 15 years as this notebook.
Wow.
I wrote it for my kids. Basically, I was told to go home and get my affairs in order about 15 years ago. And it suddenly struck me that I'd been on this really horrific journey, and that everything I'd had to learn the hard way was sort of going to get lost. So I started writing it for them, so that they would have a guide. And I happened to mention it in passing one day to my agent, because prior to this, I wrote fiction. And she just said, stop what you are writing. I need this book. I need this book. I'm looking after my parents. I need this book. I'm looking after my baby. And then suddenly, and it was brilliant, because Short Books jumped on board. So that's the publishing home of the late, great Michael Mosley. They could really, really see the value of a patient-to-patient guide, because I do think it brings another sort of a nuance and level to it. And certainly we've seen the How to Talk community on my Instagram feed. They're so engaged, they're so concerned, they have so many health issues that they don't necessarily feel are being addressed. So
the other thing in this the Parliamentary Health Bill, was the abolition of NHS England. Now it's happening, but is it a good time to abolish NHS England? I don't think it is. But
no, I mean, one could question, what did it do? Are we going to miss it? Was there duplication with it running alongside the Department of Health and Social Care? So that's probably a separate conversation. But let's just look at the it's meant to be about. It's been billed as it's saving resources and bureaucracy. But from what I can see, and I'm just reading from my notes to make sure I get the right figures. And you, Mr. Dataman, please tell me if you think I've got this wrong. So I can see that the Treasury put aside £860 million across years 25, 26 and years 26, 27, just purely to pay redundancy costs for staff, okay, from taking this body away. Then there are actually wider job cuts, because it was extended to job cuts across the integrated care boards, and that brings it up to about £1 billion. The projected savings are meant to be an annual saving of 500 million to £1 billion by the end of the current Parliament. And we put that into the context of the current expenditure of the NHS budget is about 242 billion. However, so that the 1 billion, the 500 million, 1 billion saving, that's a saving, but when I see at the chaos that this restructuring is causing, there is complete inertia in that I have in my local, because not only have we got the abolition of the NHS England, there are a lot of integrated care boards are merging. So in my neck of the woods, Surrey and Sussex have just merged, hence why there is redundancies at this level, which means that I have all of these people who are meant to be making decisions, not making decisions because they don't even know whether they've got a job or not. And at the same time, we're trying to do the neighbourhood health plans at the slightly lower levels. And we don't know what we can and can't do. We don't know if there's resources coming. And essentially, it's everything seems to have come to a standstill. And yet things need to be going on. And I think that this is probably causing financial losses. And what are the gains? At the moment, I'm not seeing them. All I'm seeing is a bit of a power grab as everything is being centralised towards the government and everyone having less say at a more local level.
Yeah.
You agree?
I do agree. And I think I was talking to somebody from NHS England literally last week, and she's involved in one of the sort of high-powered conversations that are taking place, but she doesn't know whether she's got a job or not. She was telling me actually that she's trained as a physio, so she's thinking, well, maybe I'll go back to being a physio again. But how crazy is that? At the very time that we're trying to reduce waiting lists, the very time we're trying to improve things, this top-down reorganisation. Just to highlight that Wes Streeting said in opposition there would be no more top-down reorganisation. And abolition of NHS England doesn't sound like top-down, does it? Transferring care, transferring GP negotiations to local ICBs doesn't sound like top-down, does it? Telling the GPs what their contract is, that doesn't sound like top-down, is it? I mean, frankly, the whole period of time that Wes has been in charge, it's been top-down. I'm going to have a little punt that he might not be a great prime minister. So anyway, let's ignore that one for a moment. That's another story for another day. I agree with you. I think there is this sort of inertia at the top, and I don't think it's helping. I mean, there was a whole number of queer. I've sadly watched a few health and care social committees where they've asked lots of questions about can they afford the redundancies and all those sort of things. Yes. So it's going to slow everything down, I think, and it is slowing things down, and I think that's a real problem. So it feels a bit like, I don't know, the whole thing feels a bit treacly, doesn't it? It's sort of anything particular.
Yeah, well, obviously I'm not in the clinical team, so I don't deal with people's referrals, but generically speaking, there's obviously a significant amount of burnout. It's the fact that people haven't been supported. But they were supported a little bit during the pandemic, but they haven't been supported afterwards. Most of the COVID hubs set up to support people, cynically speaking, partly because I think it looked good. To be fair, they were good, but they were doing it partly for face, I think, because testament shows now that they've gone. They've nearly all gone. Almost there's maybe the other literally one or two left, but they've basically gone. And what else has gone also? Crazily, and most people aren't aware of this, and if you tell most people, they're kind of quite shocked, especially because all employers have a duty of care, and obviously this is the biggest one that we have, in the fact that quite recently the mandatory requirement from NHSE, so certainly within the English healthcare system, to support staff to have some sort of wellbeing initiatives that came and was managed by NHS England, that mandatory requirement has now been abolished. So if you think about that, if you step back and kind of think about the fact that in an organisation of over 1.3 million people, there is no kind of requirement to support people's mental health. And what does exist is kind of very patchy. So what was there before, apart taking out the COVID hubs, was probably kind of insignificant, it wasn't doing the job. It was maybe things like online wellbeing or yoga and stuff, which obviously I'm sure everybody's got an opinion about, probably not positive. But the point is, there was something there. There was at least the intention to support people. And now it's sort of a perfect storm of things because COVID is not over for healthcare staff, psychologically speaking, because the impacts of that will be felt for many, many years. So, and on top of that, you've expected people just to carry on as if nothing's happened with no additional support. We are massively understaffed. We have over 100,000 vacancies across the NHS. A significant portion of that is clinical. And therefore, people are going in, day out, expected to just carry on, but with zero support given to them.
And can I just put that into context, Samantha, if that's okay? Just to kind of, so that people can really appreciate how dire this is. I had a meeting with some wellbeing leads that I'm not going to name where they were from. And I spoke to this particular person. I said to them, how many people in the trust do you look after? And this person said 15,000. I said, okay, and what's the team? And he went, me. I said, what, one person? to look at. And he went, yeah, and I've got colleagues that's even worse. And I said, well, how are you managing it? He said, well, we don't. He said, I can get posters in and I can do this. He said, but so I'm doing training about peer-to-peer support and how to set that up in hospitals and how to kind of help support. But you've got one person as well as another job that they've got being the wellness lead. And this is how dire this is. And yet, if you compare the amount of money that's probably spent on sick leave, the amount of money on agency in relation to that sick leave, and also, as much as it's horrible to mention, it is the medical negligence part of things, you put those together, that bill is going to be significantly higher than actually investing in your staff, having good staff retention, looking after the well-being of staff. It's mind-blowing. It's like, well, why is this not happening?
If we finance things privately, then we're doing this kind of like magic trick.
Yeah, magic.
The balance. Unfortunately, it's not. And in this instance specifically, I hope elsewhere it is, but in this instance, magic isn't real, and that's been contested by, for example, the Office of Budget Responsibility have called this idea of keeping debts off balance sheet. They've called it a fiscal illusion, and actually, the reality is that it not only is it not kind of better for the public balance sheet because we're pretending that we're keeping it off, and there's something to be said there as well. In the newest iteration of PFI, which they're proposing it's going to be treated as if it's on balance sheet, which is quite kind of vague and ambiguous. But the reality of PFI is that actually we're always going to be paying more for the same asset than we would if it was publicly funded entirely, because there's always going to be money leaking out of the system in the form of profit. These private financiers want to invest in the NHS because there's guaranteed flow of profit. People will always need healthcare, we need new health infrastructure, and that's why they invest, because they know that they can get that flow of public money, of taxpayer money, our money, back as a form of profit. And as long as we're paying out profit to them, we're always going to be paying more for the same assets. And I think that really bears out in some of the figures you can see now around the cost of PFI. There's a NHS trust in Essex which built a hospital. This is one of the worst ones. They've paid effectively 27 times over for that. They've paid 27 times over for that hospital when you factor in all of the PFI payments. There's an argument to be made that, in PFI, you're also paying for the maintenance of the asset. So that's some of that cost factored in there. These PFI contracts, they also maintain the hospital. But if we zero it down just to interest, I think this is really interesting fact from every doctor. In the last 5 years alone, we've paid out £1.8 billion just in interest payments. PFI interest payments, and what that is equivalent to, I find billions of pounds incredibly difficult to think about in real terms. It's such a huge, unimaginable sum of money, but that will pay for the starting salaries of over 50,000 new doctors. So when we're talking about, the crisis of corridor care, people, long waiting lists, one of the things we should really be looking at how to solve that is, where can we cut out this waste that we're giving away to profiteers and use it to pay for actual materials, much needed resources and staff on the ground who are the people who are going to help people be better and more healthy. Yeah. Just seems like a bit of a no-brainer.
It does, and even the National Audit Office and the parliamentary reports have suggested, I was reading this up, that over the lifetime of a PFI contract, it costs 70% more on average. I mean, you've given me a much bigger one, but on average, it costs 70% more than doing it with borrowing from and increasing the national debt, sure, but actually because the government can get interest rates at a very low rate relatively. You're right, it's a bit of magic, but actually it's really bad magic, isn't it? It's the worst sort of magic.
Of the NHS that's represented in the 10-year plan, and I would say I don't know if people still buy Seaside Rock in summer with a message running through it. But I talk about West Streeting's 10-year plan has privatisation written through it like a stick of...
Yeah, it does. Yeah.
And he's relying on private sector for getting the waiting list down, for building new premises, He's postponed the new hospital program, which is a tragedy because that's actually essential for efficiency of the health service. But he's also opened the door to bringing the private sector into commissioning and planning of services, including workforce planning and planning of new estates.
I agree with what Tony said. Rebuilding morale is a critical thing, because one thing that West Streeting didn't really seem to acknowledge, but which is very obvious, is that the NHS is essentially the people that work in it. And so if you damage their morale, you're damaging the organisation you're meant to be running. And similarly, we talked about the very aggressive approach to performance management that will produce gaming. It has already produced gaming, and gaming is an incredibly dangerous thing. It means that people distort clinical priorities in order to hit the targets. What we need is to get back to clinical priorities driving treatment and trusting the judgment of managers and clinicians, rather than thinking that a simplistic and aggressive approach to performance management will somehow produce a turnaround. So I think it's a time of fantastic opportunity for a new health secretary. You ask, can we help?
All of our organisations, I think fundamentally listening is what Wes wasn't very good at. He was very good at talking and not very good at listening. And to be honest, I think we all got a bit fed up with that with the Tories as well, where they weren't listening. They were very good at talking, and I think what we do need is a listener. I'm really hopeful that could happen in this next season. That we have somebody that is willing to listen, learn from the mistakes, and actually I agree with you, Mark, in terms of what you were saying. Labour did a really good job. In the 2010s, the early 2000s, sorting things out. It was the best time I've ever worked in the NHS, and I've been in it nearly 4 decades. And I think it wasn't that long ago. And I think that's the other thing. The reality is if the early pioneers of the NHS were given the NHS as it is today and said, should we make it better? They'd go, oh wow, this is incredible. It's so much better than we'd ever hoped it could be.
I think we're hoping for what sometimes people pay lip service but don't quite appreciate what it would mean. So what I want is, I was going to say, an easily accessible, friendly, welcoming primary care service. And I say welcoming because I think for lots of patients, wherever you go, it feels like there's a label. Patient's not welcome here. You can be triaged, diverted, delayed, re-referred, rationed, whatever you like. And that's what can happen to you. So I want primary care which is welcoming, so people don't hesitate to go. So they get a timely consultation with someone they know, a doctor, and then may see other professionals. And then there's very easy and timely access to hospital referrals, diagnostics, and other services, which may be co-located, may not be. Mental health, welfare rights, social care, public health initiatives, and so on. And that is the model, but it's not imposed. I mean, we talk now about neighbourhood centres. It's something that's organic, and it's allowed to develop in a way that respects and makes best use of the local population, the local services available, and staffing. But the other thing is that there's huge disparity, as you know, between wealthier areas and poorer areas. And those need real incentives for staff to go and work in. And those have, at the moment, they get less funding than better off areas, which is mad. So I want a huge redistribution of funds to poorer areas. But I think the other thing is that can't come out of a robbing Peter to pay Paul. It can't come, nothing's doing that well. And it can't come from robbing hospitals, because those also need. So what I want is this primary care that's easy, accessible, friendly, welcoming, effective, and can refer. But hospitals to be resourced so that they can do. We're talking about the day jobs. We want access to GPs, ambulances, A&E, and hospital diagnostics and treatment. That's the day job. And I think until that's stabilised and has caught up a bit, any thought of reorganisation or shifting from hospitals to, the community or any other sort of reorganisation misses the key point. The day job is getting those basics right. And that means having more doctors, more nurses and other staff, more equipment, better premises, and making primary care an attractive, rewarding profession and a welcoming resource for patients. So, we'll come on to other things, but I mean, that's my dream of what I want. And how to achieve it would be the next thing. So, because primary care it can, well done, it can reduce hospitalization, reduce mortality, all the stuff we know, increase GP productivity, aid prevention or deterioration of later stage illnesses. It can do magic. It can do more with end-of-life care. It already does most of the mental health and psychiatric care, but with poor resourcing. So I wanted sort of celebrated, acknowledged, and available.
We also have that. We've seen what the NHS can be, has been, and you have to hold on to the hope that it can be that way again, and it can, based on funding and government decisions. So I have hope it will get better if we all keep advocating.
Not the NHS Again, a brand new podcast series released every Friday, which we'd love you to subscribe to. It's an opportunity to hear about the NHS, all things NHS, conversations, viewpoints, discussion points. It's going to happen every Friday, and we'd love you to be in the journey with us. So, can you subscribe? Not the NHS Again? Why that? Why not the NHS Again? Well, because it's really important. We need to get it right for everyone. We need to get it right for you, our kids, our parents, our families, our neighbours. It involves everyone. So, not the NHS Again? Join us in the conversation every Friday.